It gives me great pleasure to welcome Courtney to our parent podcast called Ask the Orthodontist. And even though this is not necessarily a straightening teeth question, it's definitely an important question when we're talking about the cause of crowding, which is a narrow jaw. And what causes a narrow jaw? Many times it's airway obstruction. And today we have Courtney, who's going to be discussing with us some of the alternatives parents have when it comes to large adenoids and tonsils. So Courtney is based in Indiana, and just for my interest, what's the capital of Indiana?
Indianapolis.
Indianapolis, right, where the famous car race occurs, right?
Yes. Yeah, that's right.
Right.
Indy 500.
And her practice is called functional face. I like that because my practice is called full face orthodontics. I think it's kind of like got a
Yeah.
nice combination to it. I believe you have been a clinical dental hygienist for 13 years, but in 2016, you discovered orofacial myofunctional therapy, and you pursued training with the IAOM, which is one of the major certifying bodies for both US and Australia. It's for those who want to look at that more. It's called the International Association of Orofacial Myology. And what I really like is you've gone on further than that, and you've done your Buteyko breathing, and you've become a certified sleep science coach, which is, I think, just all links in very, very nicely. So clearly, Courtney has a strong passion for helping people with sleep disordered breathing and TMJ dysfunction. I've seen some amazing posts where you've been helping people on the Facebook group where parents are asking questions about their kids' large adenoids and tonsils and what may be a non-surgical intervention. What made you I think just recently you've even extended your scope even more, and now you're a certified infant feeding counselor. Can we start with what got you interested in the feeding side of things, or the
The infants.
lactation?
So yeah,
Yep.
it's there's different certifications for like pre-IBCLC, the board certified standard. So it's like your initiation into that world of infant feeding. But it came from knowing that so many of the problems that we treat do start in those early years, early infant feeding challenges.
Yep.
One of the best ways to grow the face and the airway is to be able to breastfeed your baby. And
Yes.
if a family cannot or chooses not to for some reason or other, there are strategies and things that we can teach families
Yep.
to optimize growth and development. Also, so many families aren't taught, the importance of being able to nasal breathe from those from
Yeah.
infancy.
Yeah.
And
Yeah.
so mine's kind of a unique angle than maybe a standard lactation infant feeding counselor is that I'm combining, hey, let's get the baby to be able to eat appropriately and well,
Yeah.
but what
Yeah.
are some other things that we can do that encourage appropriate growth and development when we
Yeah.
start to get to solids and we're the nasal breathing, the oral function, the sleep, the whole thing. So
Yeah.
hopefully going to be able to prevent some of these problems that we see in older children and adults by educating the family sooner.
I think, when parents in particular, ask me what's the cause of my kids' crowded teeth, I was taught 40 years ago when I graduated, it's genetic. You have big teeth, your husband has a small jaw, and that's why your kids got. But we know it's more epigenetic. And certainly, where does it start? I reckon it starts from the moment the child takes its first breath.
Mhm.
And all the parents know about the immunological benefits of breastfeeding, but what they don't realize is breastfeeding is the nature's orthodontist, right?
Right. Yeah.
Putting that tongue in the right position. You can't breastfeed and mouth breathe at the same time. The endochondral ossification of the lower jaw coming forward to capture the milk. I mean, there's just,
Mhm.
nature gets it right 100% of the
Yeah.
time. So,
Yeah.
but what is interesting, and I don't know whether you see this, but I've seen in my 40 years of clinical practice, in the last 20 years, every second kid seems to have tethered oral tissues, and I don't know. I have my own theory on that. I don't think it could be genetic. I think
Mhm.
a lot of parents in Australia are told to be on folic acid supplements and things like that. So whatever it is, one of the main reasons in Australia, parents are not able to breastfeed for the required time, which is recommended of 2 years, is because of these tethered oral tissues. And maybe we'll come circle back to that. But I think
Yeah.
what you're doing is fantastic, because if you want to do true interceptive orthodontics, it's kind of to intercept that kid from birth. So it's
Yes. That's primarily what I am seeing with the infants. And every once in a while, maybe you've heard the expression, when you have a hammer, everything's a nail.
yes,
So
yes, yes,
I try to be really mindful of that like, I'm not overseeing it. But, a few weeks ago, I had a mom who was having the challenge of feeding her newborn baby, and she
yeah,
thought, maybe she had oral ties. And I'm like, she does not. That's not the
right,
problem here. And so it's
yeah,
something, I needed to help the mom. And I was like, it's so nice to see a normal functioning tongue on a baby, because for a
yes,
while I wasn't even sure if they still existed, but they do. So,
right,
but yeah, that's a lot of what I get. These families have been to, either been told that they have it, but it's mild, or they've been seeking support they can get around here, they can get support sometimes up to like 3 months through the hospital
yeah,
system if they have their baby there. But I've literally had
yeah,
some moms say, they say they can't help me anymore and they don't know what's wrong. So,
right.
but yeah, there's a lot of that going on for sure.
Okay, so maybe I'll start by circling back to the tonsils and adenoid situation.
Mhm.
How did you? I mean, I've seen your background; it's kind of amazing. But how did you become interested in sort of natural, or what we call in Australia, holistic backslash conservative approaches for the children who have large adenoids and tonsils?
Um, well, I would say that I'm naturally inclined that way. When, I started to become a young adult and started being responsible for a lot of my own healthcare decisions. Um, I was just kind of initially in that mainstream kind of medical model, but also began very just my nature is to ask why.
Yeah,
And so I began to kind of treat myself that way. I would often call myself kind of scrunchy, not
yeah,
not hardcore, but definitely going that way. And as I've gotten older, more and more things, if there's a way that I can treat something naturally or find the reason behind why, and I don't have to take some kind of, pharmaceutical for it, but I can, address it through medicine or lifestyle. That's my
yeah,
preference for myself and my family. And I think that's part of why I was drawn to myofunctional therapy, because that's one of the first things that I remember being taught was you have to address the why. If you don't address the why, you'll never rehabilitate the function. So that kind of naturally married there.
yeah,
And
yeah,
then the families that I saw over and over again dealing with these challenges, even if they're not crunchy or holistic or naturally minded, maybe even the traditional Western kind of medicine, family coming to me, their first thing that they want to do is not usually a surgery. They're concerned about potential long-term health consequences, or even if
yeah,
not that, surgery.
yeah,
Their kid's
yeah,
going to go under anesthesia. We're removing a body part. Is
yeah.
this really all that I can do? And so having that mindset, and then so many families, one after another, I kind of just uh, maybe became forced to be like, how can I support and help these families? What is out there? What information do we have to better support them? And it just kind of grew from there.
And one of the lines I've seen you on your website, I love, and it's when people ask, when people can't breathe properly, kids, and they've got obstruction, and some people say, let's watch and wait, maybe they will grow out of it. Your response was, every night of poor sleep is a missed opportunity for growth, brain development and healing. That's such an important line. I think that kind of summarizes what we're all trying to do
Mhm.
in this sphere. Um, so, um, so can we just start by talking about some of the natural therapies you would advocate for a mum who has a kid that has large adenoids and tonsils, and maybe they want to revisit the need for surgery later, but they want to do something now? Can we start with that discussion?
Sure. One of the biggest ones that I see is really addressing allergies.
Yeah.
They're a huge, huge problem, especially where we live. We're in a river valley, and we actually have also a lot of industrial stuff. So we have environmental things. Really bad allergies was something that I dealt with. My oldest son had obstructive sleep apnea when he was about 6, and it was
Yeah.
around the timing that I was learning all this stuff. So he was a great first kind of case to work through. but he was allergic to everything inside and outside.
Right.
And it can be
We have
hard
we
to
have
really
a saying. We have a saying in Australia for someone like that said, that kid is allergic to their own shadow. That's like an Aussie way of saying
allergic to
the
life, right?
allergic to everything. Exactly. Yeah. Sorry.
Yeah. And no, you're fine. And, you've probably seen this where there's some cases where the kids are symptomatic and you look in the back of their throat and their tonsils look normal. So the parents don't think that there's a problem there. But
Yep.
we've seen time and time again that the size of the tonsils does not reflect the size of the adenoid. So sometimes only
Yep.
the adenoids are problematic. And much of the time it's with allergies. Yeah, so that is one of the biggest things I see that you've got to do that, and it's such a big problem for kids. And there is research that shows that just, specifically like dust mites. So like in the bed
Yep.
and the mattresses, the more severe a person's allergy was to that, the worse their sleep disorder breathing was.
Yep.
So whatever a person can do, it's not with my own son, one like cool little tip I learned from the doctor was when he was battling those so bad was when he goes outside, it's not just getting in his nose and maybe in his mouth, it's in his hair too. So even
Right.
if maybe he didn't go out and get dirty, but you guys went around, he's so sensitive to this stuff. His hair needs to be washed and rinsed every single night because it'll be in his
Yeah.
hair and then goes and lays
Yeah.
in his pillow. And
Yeah.
then, unless you're immediately changing the pillow every single day, he's breathing that pollen in every night.
Got it.
And so, that can be really extensive with like air purifiers in the home. Um, that we will maybe talk a little bit more about the nasal hygiene component and just getting that
Yep.
filter so that it can work and do its job in the nose. And then I just learned recently from a allergist that a lot of times the medications, just like a single thing for the allergy, is not enough to really give the comprehensive help that you need.
Yeah.
So it may be an oral supplement, which there are some natural solutions to that, or medication, oral medication, but also a lot of times you'll need to address the other points of contact with the allergy, like if it's in the nose, if it's, nasal symptoms, eye symptoms, skin symptoms, and that also those allergies, most of those medicines or supplements will just address a histamine response, but
Yep.
there's a lot of other inflammatory things that happen on with the body with allergies. And
Yep.
so those other parts have to be addressed too. But that's one of the biggest things I definitely recommend people look into. It is kind of funny to me though that many people are resistant to even looking into whether or not they have allergies or treating them. Do you ever experience that?
Everyone in Australia self-medicates. They all say, "Oh, my kid has hay fever." That's the term they use, but they really would just go to the local pharmacy, or I guess what you call drugstore, and they will just, um, uh, have a over-the-counter antihistamine type med.
Mhm.
Uh, um, Telfast is a big one. I'm not sure it'll be the same brand names as you guys have
Right.
in there. Yeah. And they just seem to think, oh yeah, I just control it with that, but they don't really go and bother to identify, what is the allergen. And I work
Mhm.
with some very good allergy specialists who will do the blood test and the skin prick test, and help that parent. And now, if the kid is not reactive to anything, then kind of we look elsewhere. And to me,
Right.
elsewhere is really the gut.
Right.
There's so many kids who have. We're talking about allergies. Well, I will use the term intolerances, right?
Right.
To wheat, dairy,
Mhm.
that sort of thing.
Yeah.
If I can ask you another question,
Yeah.
parents are obviously shocked to hear that their kid has large tonsils and adenoids, right? And they'll ask
Mhm.
me, look, is that normal? And secondly, they'll say, what are some of the signs that suggest that these large adenoids and tonsils are affecting their breathing or their sleep, or what we look at, which is their oral function? Because I think for a lot of people, the first time that they're identified as large adenoids and tonsils is when they see the orthodontist, because as you know, we take that standard radiograph, whether it's a CBCT or a lateral ceph,
Mhm.
and it clearly shows us the obstruction. And that's the first time that parents kind of, I always have a picture of a normal airway and one with an airway where the tonsils and adenoids are occluding. And I use that as a starting point. But can you maybe address for parents, statistics for large adenoid and tonsils. I think we both see it more and more, maybe due to what you've just discussed, which is allergens, etc. But what's normal, what's not normal in T's and A's?
Well, typically we'll see that some kids, well, the majority of kids around, I've seen anywhere from the ages 2 to 6 to 3 to 7, just typically will have larger adenoids. Their immune system is kind of being built
Yep.
up and
Yep.
it's getting really activated. So in that sense, it can be normal to see them enlarge at that time, but not necessarily. Like the key is, I will often say to families, large tonsils and adenoids are not a problem unless they're a problem.
Yeah.
And
Got it.
so some of the things that you were talking that might be signs outside of like you can visualize them, so that's great if you can get a lateral
Yeah.
stuff. But these kiddos usually are symptomatic. At nighttime, they often are restless. They might sleep sweaty. They might sleep with their head kind of tilt back to kind of open that airway. I'll use that kind of head tilt, chin
Yep.
lift,
Yeah.
this PR analogy. Like, what do we do for these people to open their airway? That's what we do, right? They may snore. They may gasp, may have pauses in breathing, but not necessarily. A lot of these kiddos, they might just show up as more restless or maybe clearing of the throat, things like that. And then bedtime, urination. So especially past
Yep.
the time that
Yep.
they shouldn't have been, see that way too much. And kid families are often told it's normal. They'll outgrow it when they're a
Yep.
teenager or something like
Yeah.
that.
Yeah.
They may be difficult to wake up in the morning. And a lot of these kids won't say that they're tired. So when it comes to like the daytime behaviors, you might expect, well, this kid slept terrible. They're going to be so tired. But many of the times they won't. And that's where some of those ADHD, the
Yeah.
impulsivity, the hyperactivity behaviors come in because the
Yeah.
kid is just literally trying to stay awake.
Yes.
Um,
Yeah.
and then obviously we've all as adults had a poor night's sleep or two, and we know
Yeah.
that we can be irritable and not be able to focus or things like that. So, um, you know, us working in a space, we see this so commonly. That was actually how I got my son's ADHD diagnosis. I just am so thankful for the timing of me getting that information because right when I got that diagnosis, I said, can we get a sleep study?
Yeah. Yeah.
Because his was more those daytime behaviors and not so much the nighttime
Yep.
behaviors. Daytime
Yeah.
was the big issue. Some of these kids also have growth concerns because the growth hormones they're not able to get into the stages of sleep that they need to for those appropriate hormones to be released.
Right.
So some
Correct.
of them might be on the right trajectory with their growth, and then they start to trail off or be maybe smaller than their peers.
Yeah. Yeah. And I think I always tell parents to, look out for the kid who is regularly snoring and loud snoring. Look out for
Mhm.
that kid who's grinding their teeth a
Yes,
lot.
grinding for
Yeah,
sure.
we definitely talked about the nocturnal enuresis or bedwetting. I find recurrent middle ear infection is a big sign as well, right?
Yes.
And just that kid, you just know that is not concentrating or has a short attention span because I'm glad you mentioned ADHD because Australia is like the Ritalin capital of the world. We have the highest consumption of Ritalin than any other country in the
Really?
world, which is crazy.
Wow.
And
Yeah.
I think the reason is it's misdiagnosed. The signs
Yeah.
and symptoms of what we're talking about are almost identical to true ADHD, yet no one
Mhm.
investigates those, and the kids put on meds, which, as you know, actually further worsen their sleep cycle. So what I say to parents is what they can observe is, the noisy sleeping, the restless sleep, the daytime behavior, et cetera, et cetera. But I think for dentists, oral health therapists, oral health practitioners, what we see a lot in the mouth is that really narrow palate, that classic, and I say to parents, look at your kid's eyes. You see that venous
Yeah.
pooling,
Dark
et cetera.
circles. Yeah.
Yeah. So I think there's lots of things that they can
There's so
pick up.
many symptoms. Yeah.
Yeah. Yeah. And then continuing on with allergies and maybe sort of looking at those. What are you doing as far as further evaluating maybe gut health? Because I think the more I look into it, there's more people I work with now. I never thought I would work with GI specialists as much as I do now, and they are doing everything from stool samples to blood tests, et cetera, et cetera. And just a simple thing. constipation is one of the leading causes. And if you look at some of the papers between large T's and A's and constipation, it's ginormous. So I think that
Hmm.
also goes back to the whole absorption issue. So can we talk
Yeah.
a little bit? What
Yeah.
else would you look at non-allergy for these kids if we are
Non-allergy
going to?
wise.
Yeah,
Right. A big one that I recommend for sure is looking into their nutritional status, particularly
yeah,
with vitamin D is huge because
right,
it
right.
plays a role in their immune system, supporting their sleep and their breathing. And there is lots of research that shows that there's this inverse relationship. So really low vitamin D is associated with higher, more severe right severe levels of obstructive sleep apnea. Not saying it
Yeah,
causes it, but they
yeah,
consistently see that issue. And that makes sense, when these kids are often chronically sick. So they get, and they say when they take out these tonsils and adenoids, what would we find in them? What's the cause? Frequent infections, bacteria and
yeah,
viruses. And that was something that I saw play out with both of my children. They, kind of tease me at the house that I'm this vitamin D vigilante. And I thought we were doing pretty good with getting them outside
yeah,
and occasionally supplementing. And we're eating the salmon and it's fortified in the milk and all this stuff.
yeah,
And my second son, for example, had 4 rounds of strep throat in 5 months. And I was like, we got to go get this tested because he's 14, not really wanting to supplement like mom's wanting him to. And we confirmed, yeah,
yeah,
he's really low. And so those things are huge. And then with and my own son who had the sleep apnea, that since we've progressed through that, we've been working with other health issues with functional medicine, which is really, really huge, and which I think that you're talking about is where you get those kind of the deeper blood work with the nutritional status, the stool samples, looking at the gut permeability, like you're talking about. We just unfortunately seem to live in a society where our bodies are taking on a lot of onslaughts with
yeah,
different things and healing, my son's own gut and things like he doesn't have celiac disease. His aunt does. His aunt has celiac, but he has a very, his blood work showed that he was very sensitive to gluten.
yeah,
And eliminating that, his inflammatory markers were very high on different fronts.
yeah,
And addressing those things with specific, targeted supplementation and some elimination of the different inflammatory things that bothered him
yeah.
significantly improved his health. And it's
You
not
know,
always easy to get that done.
yeah. Well, because a lot of people that listen to this podcast are not just parents, but allied health professionals. And I always say to dentists, like, when you see that kid that has that really weird white spot just on one tooth, not like what we associate with, we use the term MIH. I'm not sure whether you use that in America, where it's called molar incisor hypomineralization, right?
Mhm.
Which is a bit, but when you see just kind of one incisor with that sort of white spot lesion and you don't see it on the other teeth, that's a dead giveaway to investigate celiac, right? Because,
Mhm.
as dentists, we're all taught to drill, fill, and bill, but not really look at the cause, right? And how can
Mhm.
we, rather than put a veneer on that tooth, that should be a warning sign for us to maybe look further at gut health. And so that's a white spots isolated to single teeth and celiac. It's a huge, huge correlation. So I'm glad you kind of brought that up. Now, I noticed in one of your previous posts, you were talking about mold in the house and moisture. Can we explore that possibility a little bit more? Because sometimes that's what our parents don't appreciate.
Yeah, that can cause a lot of inflammation. There is something, again, it's kind of in the functional medicine realm. You may have heard of it, but there is it's called Staphylococcus coagulase. I need to say it. I need to say it all together. Have you heard of
Yeah,
Marcons?
yeah, yeah, yeah.
Multiple antibiotic resistant Staphylococcus. What am I missing? I'm missing a letter there. Coagulase, Staphylococcus. Anyway, it's a naturally occurring bacteria in our body,
Yeah,
um, but it can have overgrowth, especially in the presence of things like mold. And that can cause a whole inflammatory response in your body.
Yep.
Again, something that's, it seems like it's partially accepted in the medical. I think it's just a matter of time before it is, but it's called chronic inflammatory response syndrome, where
Yep.
your body is just really getting hit hard with the inflammation throughout, and there just can't be a state of healing. That was something with my son that we had to address. He had this overgrowth of that bacteria, so he was resistant to multiple antibiotics with that, and also Klebsiella, multiple antibiotic Klebsiella pneumoniae, because he had chronic sinus infections, dark circles under his eyes, headaches, and multiple infections. And it seemed that it, happened to be due to a mold exposure. So it's really hard to sometimes get the help that you need for that. But that's something that I feel like is commonly missed. And even in new construction homes, people are having issues with, just surprisingly, I hear stories, here and there, people, our home was new, but something happened, some kind of poor construction, and there's a leak somewhere, and mold, this horrible black mold is growing in, a
Yeah.
place that they didn't expect. So
Yeah.
it can cause a
Yeah.
lot of problems.
And when we're talking about sort of targeted natural strategies for reduction of inflammation, and hence back to our topic of T's and A's, I always talk about the syntax of care to my parents, and I work a lot with orofacial myalgias, because I think that's the important thing. In fact, when we finish editing this podcast, I'll put a link to two papers that I've published both in Journal of Clinical Medicine. One is where we had a cohort of children who had large adenoids and tonsils and narrow palates. And of course, their parents, just mainly because of insurance, couldn't afford to have the T's and A's out. They had to go on a 1-year wait list. So during that 1 year, we did the expansion because they needed it, right? And then I measured their airway via a PSG before and after, and we found the maxillary expansion actually had a better reduction in the AHI compared to just the T's and A's. So I always say to parents, like, if you're pondering a non-surgical solution other than gut health and allergy, why don't we fix that upper airway? Why don't we expand the jaw? And as you know, that the importance of nasal breathing in the whole vasodilatory effect of nitric oxide, and I think parents sometimes don't assume how unnatural it is to mouth breathe. And I say to parents, well, look, would you be concerned if your kid started putting food through his nose? Well, of course they would, because that's just not normal. But they feel that mouth breathing is. Could you maybe just guide us through the benefits of nasal respiration when it comes to reducing inflammation?
Oh, it's huge. I always tell people, I'm like, what do you think your nose is for? And they'll be like, oh, breathing and smelling. I'm like, well, as far as we know, the nose performs, at least right now, like 39 different functions, and we really
Yeah.
underestimate its value. And so one of the things I talk a lot with people is, we kind of talked about it real briefly, but initially, like, it's your first filtration system for viruses, illnesses, anything floating around in the air. And I liken it to, a furnace, a filter on, your furnace or your car. It's going to have to be cleaned in order. There's no replacing this one, but we need it to function well. So there's the filtration aspect of it to lower your, we do know that people who mouth breathe are more prone to upper respiratory infections. So you will be healthier because of that. In addition, we get this really great molecule, most of it through the active nasal breathing, nitric oxide, which helps with the delivery of oxygen to the rest of our body. It's also more calming to the body to breathe a nasal breathing pattern. The mouth breathing kind of puts people in the sympathetic nervous system response, which increases stress. Another way that people, we're more likely to be ill. It's also, we're going to get more oxygen through the active nasal breathing, 10 to 20% more oxygen versus mouth breathing. So mouth breathing is more fatiguing, and all the other, like, I always say at minimum, it starts with like bad breath, but then increase of tooth decay and gum disease. And then the tongue's going to be low. You're blocking your breathing. So there's like outside of an emergency use, thank goodness we have the mouth, but there's so many health benefits to nasal breathing. Um, we've got to get the kids back to that.
Yeah. And I think one of the big things that I talk about with my parents is rehabilitating the airway, right? So it's two stages. One is to open up the airway, but the other is to rehabilitate it. I say to parents, we teach our kids how to walk. We teach them how to talk. You believe it or not, you've got to teach them how to breathe through their nose if they've had like a 7-year mouth breathing habit. So to me, my syntax of care is always clear the airway. And we're talking today about non-surgical methods of doing that. Then widen the palate, then look at all the oral tissues that are tethered and release them. And then most importantly, the myofunctional therapy, which is, I know, where, you all have excelled and where your studies have led you to. So, so for the parent who's going to say, I know there's a problem, but I have no idea where to start, right? Because you see that all the time. They say, well, who do I see first? The ear, nose, and throat doctor, the airway-focused dentist, the orthodontist, the myofunctional therapist, the allergy specialist. It's quite daunting for parents as to what to do when. Can you tell me how, say, seeing a myofunctional therapist first as the quarterback, I think that's an American term, isn't it? The person who controls the play, right?
Yeah.
How could the oral myologist potentially help the parents understand the next steps and maybe help navigate those referrals?
Um, well, I think one of the things that makes us unique is that because the airway dysfunction is one of the most common causes for the problems that we treat, we do build that community and that collaboration, and we know who can help us.
Yeah,
And not every ENT, if you just call your local ENT, this is something that I assumed when I got, into this work. Well, we just call the local ENT and they're just going to help us through this problem.
yeah,
But not everyone specializes in that. Same
correct,
thing with
correct.
the local orthodontist, even though the ADA has been saying for years that they should be, screening for these problems and be aware of them. A
Yeah,
lot of them aren't. And
yeah,
so you just running to your local orthodontist for expansion. A lot of times around in our region, it's getting better, but they'll only expand if there's crossbite.
yeah,
And so, because of the work that we're doing, we kind of know those people. It might mean that you have to travel a little bit, but that person might not be right where you are. And so
yeah,
we have, I feel like, in this airway focused community, a good network of people that we can help you to get to. And if I
right.
have a family who is looking at, I don't want to get the tonsils and adenoids removed, at least not immediately, what else can I do? I'll say, okay, well, for your immune system, like there's some things that you can do here. But then I don't know, 99% of these kids see, they have these too narrow of jaws and
Yeah,
airways. So,
yeah,
okay, let's go get expansion first. You're going to need it either way.
yeah,
So here's your best shot at trying to
yeah.
avoid that surgery.
I like
And
that because you can, as we know, some kids can grow out of their large adult tonsils because they naturally shrink. But the problem is, by the time they naturally shrink, the damage for the face is done. And parents really don't get that point. They think, yeah,
mm-mm,
my kid's only 7. They're going to grow, my husband's 6'4". And I say, well, listen, they will definitely grow more than they are now, but their craniofacial growth by age 8 or 9, most of it's done. So that's a
mm-mm.
big wake up call for them. And then I also say, and even your other growth is related to growth hormones, which are probably not being released correctly. So, short stature is a big thing with these kids. So I think it's important for parents to understand the difference between timing of facial growth changes and standing height changes, which are very different mechanisms.
And even
So,
if they I was to say, even if they do, and they've had the cranial facial growth
yeah,
permanently altered, they're more likely to be that adult later, even if they're like fine later, maybe in their
yeah,
teenage years or early 20s, when they got all
yeah,
this collagen elastin in their youth on their side. When they're 40,
yeah.
probably not. Probably not
Yeah.
gonna be fine then.
And one thing I don't recommend, I recommend a lot of things, but I don't recommend a sleep study. And the reason I say that and I'm not sure what it's like in America, but in Australia, a sleep study for a child is hugely expensive, and it misdiagnoses so much stuff because it's really just looking at that apnea index. And we know these kids, they move around and their muscle doesn't collapse. So they're likely not to come back with a positive AHI. But that doesn't mean they're healthy and they're breathing properly. So I always say,
Right.
look, once we've done everything else that the kid really needs, their inflammation, their jaw width and jaw position. If there's still sleep problems, sure, that's when we may be looking more at the restless leg syndromes and the centrally mediated sleep apneas, blah, blah, blah. But, fix the obvious because I'm very disappointed when parents come back and they're told, look, there's nothing wrong with your kid's sleep. They do not have OSA. They may not have OSA, but they sure the hell have upper airway resistance, and they sure have mouth breathing, and they sure have that loud snoring, et cetera, et cetera. So I think, for those parents who are saying, oh, yes, I was told, let's start with the sleep study so we can find out what's going wrong. A sleep study doesn't actually tell you what's causing the obstruction. That's the problem, right? But I like your thought process of looking at other things. So again, I think a myofunctional therapy is a good start place, and it's certainly the ending place, because the start place, it kind of helps them to identify problems, and they can look and see, look at your child's posture, look at their forward head posture, look at their improper swallowing. And I try to say there's so many muscles involved in swallowing, but none of those should really be visible during a normal swallow. And then I get the kid to stand against the wall, and I just video them just swallowing some water. And you've seen, the pelican type behavior. And I say, listen, there's your problem. How are we going to help fix that? So continuing on from that, where do you put your syntax of care as far as release of oral ties, as far as expansion, nose and throat, et cetera, et cetera? Where would be your, and this would be just your personal view. Where was your syntax of care? Which order?
It definitely depends on a case by case basis, but I often do send people for expansion first, especially. I mean, there's some cases are so incredibly narrow. It's like I'm going to be really hard pressed to help you get your tongue where you need to go because it's so tiny. But even if they can, when it comes to releasing the oral ties, want to make sure that we've got some appropriate spacing for that. So a lot of the times we are starting with expansion first. And there might be some where we do, if we were doing oral ties first, I mean, I know the research says there's no connection with oral ties and large tonsils and adenoids, but I do see them go together an insane amount of time for, I don't know that there's not what the connection is, but I do see them together a lot. But I
think
don't really.
Zaghi, Zarush Zaghi, who's one of my mentors, his Six Flags, where, he gets parents to kind of assess X, Y, Z, definitely he's seen a huge correlation between airway obstruction and oral ties. So I think it's depending on who did the research and what they're really looking at. And again, the definition of an oral tie, how subjective that is. I always say to people now that, you've got a number of classification systems. I like Audrey Yoon's functional classification of ankyglossia. But I think, a lot of parents, I'm working on an app right now where it's going to be free of charge, where as long as a kid looks at their own eyes in the mirror, so they have a normal head posture, the parent can take a photo of the side profile, which parents never do. No, you ask a parent, show me a profile photo of your kid, they flick through their phone for hours. Of course, there's no side photo because you don't normally take that. But that's so informative for me as an orthodontist, and I think a predictor of things going abnormal. So we're working on an app where the parent can take a photo, and it kind of uses the cranial measurements, which is easy enough to look at from a child's head. By 7, most of that anterior cranial base is formed. And just to see, well, where is their maxilla? Where is their mandible? If they're both retrusive and the kid has increased vertical facial proportions, bingo, that's a kid that's going to need your help. So I think looking at craniofacial, which is, you'd think every orthodontist would, but, you made that point that the American Dental Association is probably a lot more progressive than the American Orthodontic Association. And, every time I see posts where they say, oh, yeah, but is he a real orthodontist? I say, well, look, he doesn't have to be a real orthodontist. Airway-focused dentists are sometimes more highly trained to pick up these things. And I hate to say that for my profession because, we did extra time in our specialty, but there's so many kids that are sent to me with a watch and wait approach because they haven't got a permanent dentition. And the orthodontist has not looked at the airway, not measured the palate, not looked at all the stuff we've talked about that an airway dentist would. Maybe that would be a starting point. What would you say a parent would ask at their consultation, right? To see whether they're seeing a true airway focused oral health professional. Let's call it that,
Okay. So I would say I would be having them ask, like, do you assess the the tonsils are going to be one thing that they'd be looking in their mouth. If they are taking a lateral ceph, then they should be able to see the adenoids. Do you assess those, and do you recognize that they can be obstructing breathing? Like, how do you address that? Are you assessing for tongue posture and mouth breathing? Do you expand outside of crossbite situation? Are you only,
Yes, good. That's a good one. That's a good one. Yeah.
Also, like, so many times, and this my own experience, like walking through this with my son and his orthodontics, they're not looking at the profile so much. Like, he had reached one stage of care, and he's like, well, see him when he's 12. I'm like, he's still super retrognathic. He's had obstructive sleep apnea.
Yeah. Yeah.
I don't want to leave that alone.
Yeah.
So are they really looking at that comprehensive look, not just the straight teeth? And do they collaborate with other people? Are they referring to ENTs or myofunctional therapists? Do they look at tongue ties? If they don't know how to, do they refer out for that? So
one classic one. I always say, if you're going to only ask one question, what would it be to the orthodontist? Do you work with a regular myofunctional therapist? If the answer is no, run away. Right. That
tells you right away everything. That kind of all those questions are kind of under that, because if they were, they would know to look at all those things.
Yeah. Can I start by asking about your toolkit? I note that you have a good support network. I think it's got like an 8-week challenge for these kids. Can you walk us through your natural tonsil adenoid support toolkit?
So this was something I created. It had been kind of in my head for a while, and I brought it to life about last September, I guess. And it was just all the years of working with families, the families who are looking for natural solutions. Because I would sit here in my office and I'd be like, okay, we're going to try this, and you can try this, and you can try this. I'm like, sometimes, families they'll have their first visit with us, and then they want to step away and work on something. So I wanted to create something that either the clients that I was working with, families who might be stepping away and coming back and want to address some stuff, or just people, in the online world looking for solutions, could have kind of a step-by-step protocol. That was something that I was seeing in the groups over and over again, families saying, I don't know where to start. I don't know what to try. So I actually created a group on Facebook around the same time. And I would ask families coming into, what have you tried to address this problem? And I stopped counting after a bit, but like 50 different things. So families are spending a lot of time and money on different things trying to address this problem. So I wanted to create something that was like, what are the biggest things that you can try that are going to be like the most impactful, because we do want to solve this problem as efficiently and as quickly as possible. Or while you are working through some things, what are some things that you can be doing to help maximize your child's breathing in the meantime? So I go through it's kind of evolving. I have made some updates to it since that first September release, but it has like top 9 things that parents can do, and it includes things like ingesting inflammatory foods, the allergies, expansion, the role of expansion, myofunctional therapy, nasal hygiene. So there's a whole protocol for that, and it gives parents a sheet to look at, what are the symptoms. A lot of times parents they do think their child sleeps fine, and it's not until they actually sit down and know everything to look at, and they're like, yep. And then they go through and say, okay, what have we not done? What can we reasonably start trying? And then start tracking those things, looking for, because it tells them, okay, this is what normal healthy sleep looks like. This is what your child should look like. They're here. This is where we want them. Are any of these strategies getting you closer to that end goal? And then How do you know? Because sometimes the best laid plans, parents really have thrown everything at that. You are just dealing with dangerous kind of diseased obstructive tissue and you do need to have surgery. How do
Yes.
you have those conversations? When you are working with other providers, you go to the orthodontist or the myofunctional therapist or the allergist. How do you advocate for your child? What questions should you be asking? So
Yeah.
it's kind of this comprehensive guide to help parents walk through this time because a lot of, feel like they don't know what to do or where to start.
Yeah, that'd be great. One thing also, if we have time, Courtney, what's a popular trend in Australia, maybe because of TikTok and social media, is parents identifying their kids a mouth breather and then going straight to mouth taping as their first form of treatment. Can you talk through about the dangers of mouth taping before any other evaluation?
Well, you are just literally suffocating your child. If they can't breathe through the nose, the air can't pass through the nose, or even it gets through the nose, but it can't get through the adenoids, you're just effectively suffocating them and adding to the problem. So, I have families ask me about that all the time, and I'm like, that might be something that we get to, but not until I'm 100% sure that your nose works. And a lot of times you don't even have to because once you get the airway clear, those lips can naturally close. Sometimes it does still need that support.
Yeah,
But that is not the first thing I recommend for families starting. And even if we do end up doing that, I do like the
yeah,
ones that go around the mouth where there's
yeah.
a big hole. So it's just like gentle support to bring the lips together.
Great.
But I see way too much of that. And also some of the myofunctional appliances out there, kids are put into those way too soon. I've literally
Yeah,
seen and had clients or seen kids online who are suffocating.
yeah,
One time I messaged a mom, I'm like, I'm sorry, you don't know me. I'm not a weirdo, but get that out of her mouth.
yeah, yeah,
Because it's like, no, you
yeah.
can't just ghost because if they can't breathe through, sometimes again, that's emergency use only. We don't want them doing that. We want to get them out of that state as soon as possible, but
Yeah.
just shutting it is not going to automatically make them a nasal breather.
Yeah, and on that point also, a lot of dentists, the only introduction they have to airway is for adults, and there's so many appliances so many companies, laboratories mainly, that push this. Well, if your patient snores, just give them a mandibular splint, bring their jaw forward, and that'll cure everything. What people fail to forget, air has to go through the nose first before it gets down to that position. So, what are you doing? Maybe a 50% improvement or no improvement if the problem was nasal to begin with. I think you've got to start with that nasal airway. And I certainly, go from nasal valve collapse through to the septal deviations, the inflamed turbinates, which is so common in the allergic kids we talked about, the large nasopharyngeal tonsils or adenoids, the long soft palate. There's so many things that can be obstructing kind of along the way. Can you talk a little bit about nasal hygiene? I'm certainly not a big fan of corticosteroid sprays, particularly for long term. I find that the nose almost becomes addicted to that to work. And you get so
Mhm.
many parents who say, listen, we tried that corticosteroid challenge for 6 weeks. It worked wonderfully because my kid used it. And then the moment we stop, the kid's back to square one. Or you get the parent that say, oh, the kid didn't like the taste of it and we just didn't even try it. Can you talk about things like natural saline rinse, FES as we call it here,
Mhm.
versus those? So I
Yeah.
guess the topic I'm asking is, how could you improve nasal hygiene?
Yeah, well, it's something that I feel like is severely underrated. And to your point a minute ago, I mean, I might annoy the other people that work with me all the time because I'm always saying if your nose doesn't work, your mouth won't either. So that's like one of the number one things that, you're talking about also like the order of care. It's like we got to get that nose working. And
Yeah,
so everybody, we make sure that we are on nasal hygiene. And we're like, even if you don't feel like it's
yeah,
obstructor or stuff because sometimes I'm teaching a 5-year-old to blow their nose and I blow my nose with
yeah,
them. I'm like, wow, I didn't really
yeah,
realize I needed
yeah,
to do that. So we
yeah,
sometimes get used to this certain level of breathing that's not actually optimal. And so it's something that I tell people, we really should be doing is daily, morning and night would be nice to again clear it so that it can work well. But some tips that I learned as far as, making it more comfortable is to making sure, we're pointing it the right way, not just straight up our nose and down the throat, towards
yeah,
that ear. So it
Yeah.
targets issues that we want it to. And then I don't know if you've seen it. It just was released a few months ago. It's like called the MIST study. And I don't want to misquote it. So maybe I can, this is something we can go back to, but I don't know if you saw it where they had actually compared like the steroid spray to just a simple nasal saline spray.
Right. Right.
And they had found that even like 6 weeks later, that when they had compared it to that, the symptom improvement was the same as the steroid. And as
Right.
far as the
Right.
parents feeling like my child, I'm right here before we get started thinking they probably need surgery.
Yeah.
It was just as good as the steroid and without those
Wow.
side effects. Those steroids aren't meant for
Wow.
long term. Yeah. And so it's like, that's something, it's gentler to the tissues. It's not, there's not habit forming. There's not, I think the one like the Flonase here, long-term use, you can have some damage to those tissues. And so it's a great way to improve nasal breathing and facilitate better nasal breathing. And it's just something that you got to get into the habit of, put that bottle by that bathroom sink, by your toothbrush
Yeah.
and just
Yeah.
and do it.
Yeah. Look,
Uh,
I think not a day goes past in my clinic where I haven't had some conversation with a parent or a child or a staff member where I use the word breathe through your nose, lips together, tongue on the palate. I mean, I say that again and again and again. But again, for those three things to happen, breathe through your nose needs to be clear. Lips together, same story. Tongue on the palate. Can your tongue reach the palate? Is there enough room for your tongue on the palate? So I really feel that particularly, I'm talking about the Australian experience, depending on who you go to as your provider would determine what treatment you get. So an ear, nose, and throat doctor who's classically trained is just going to go T's and A's. And even after T's and A's is not even going to recommend any breathing retraining, right? An orthodontist who's really focused on craniofacial, he or she is going to recommend arch development, mandibular forward growth, maxillary forward growth, blah, blah, blah. But maybe not look at nasal obstruction or large adenoids and tonsils. You can get a allergy specialist that, is focused on one thing. So I think the more specialized we are, the more we don't look at the bigger picture. So I think for parents, I understand why they get frustrated and why they say, well, I've been told all this stuff. I just want to get my kid better. I just want to get my kid sleeping better. I want my kid concentrating in class, but where do I start? And I think this is a discussion I see on a lot of the forums. They post some records that they've had taken at a provider, and then they're wanting help. Can we talk just a little bit about, again, if your kid has been diagnosed, whether it's with a doctor, a dentist, or an ear, nose, and throat, with large adenoids and tonsils, let's just say, what would be the next step? What would be, in practical terms, what would a parent do where they've got large adenoids and tonsils, they've been told their kid needs surgery, they're a bit reluctant to have the surgery? What would be the very next step?
If there was no access to a myofunctional therapist, I would start on nasal hygiene and get
Yep.
expansion. Absolute
Okay.
minimum, absolute
Okay.
minimum. And then do
Yep.
some basic, blood work. Because I literally have seen kids who,
Yep.
some of the strategies that I talk about, the families do one thing,
Yep.
their vitamin D was awful.
Yep.
They get
Yeah.
back normal, things get better. I've seen
Yep.
kids get rid of dairy and it
Yep.
gets better, it goes away.
Yeah.
So, um, if you have the opportunity, and so many myofunctional therapists do work online, so if there's not somebody near you, you can do that. But it is nice to have that, that quarterback on the team. But like at minimum, those two things, get started with that, the
Yep.
nasal hygiene. I have an adult right now who has mast cell activation syndrome, and she's allergic to life, like we talked about. And
Yeah.
this last April, I got her, going with her, and she said, just with nasal hygiene. And she's like, I've never breathed so well in April in my life. I didn't realize how much that I needed this.
Yeah.
Um, in the meantime, too, with their sleep, I would say like typically we find getting them on their side is better than their back.
Of
So,
course. Yeah.
it's a little thing. If we can make their
Yeah.
breathing a little bit better, if
Yes.
they got a dust mite allergy, get some allergy bedding on that bed, reduce the load that
Yes.
they're experiencing during their sleep. Because a lot of the times it's, some of these kids manage okay during the day, but the nighttime things really go south.
Yeah. Yeah. And I think now the allergists that I'm working with, once they try all the conservative measures, immunotherapy is having some good
Mhm.
success in this day and age,
Yeah,
particularly with the new protocols.
yeah.
So look, it's been a pleasure talking with you. I'm going to end the webinar or podcast by again. I'm really excited about some of the research that we've done here in Australia. Right now, this is going through the last stages of peer review, but I had a cohort of patients who had both adenoids and tonsils removed, as well as maxillary arch expansion. So they did both. And then in
Hmm.
this group, you just assume, wow, well, they should be all fine. But what we did in this group, we did a follow-up sleep study. And guess what? In a fairly large sample, 90% still had residual AHI. Now, I know AHI is not the greatest measure, but when you're doing academic studies, it's what everyone looks at.
Yeah,
But
you gotta have that.
you would just assume that, geez, they've had their T's and A's done. They've done the expansion. They're the two biggies, right? And how come this
Mhm.
kid is still not 100% fixed? And then I looked at the literature, particularly Christian Goumenos' contribution,
Mhm.
where,
Yeah,
the father of sleep medicine saying, hey, myofunctional therapy is the key. It's once
yeah.
you've cleared the airway, which is what T's and A's do,
Mhm.
removal, and what expansion does, you've got to rehabilitate the airway. And I remember when I first listened to him, he knew I was from Australia, and he said, oh, you must know this. Learning to play the didgeridoo is probably the most effective way to cure your sleep apnea. And I didn't know
Yeah.
that. And when I went back
I have
and,
some
and, and
adults that literally have started to learn for that
yeah,
reason.
yeah, and then I realized, wow, it's all those pharyngeal muscles, genioglossus, being the recruiter of a lot of those. It makes perfect sense. So anyway, in this study, all those kids who had residual AHI, we put them into two groups: those who had myofunctional therapy, those who didn't. Real simple study, big
Yeah.
sample, and the thing is. I know people are already talking about bias because those who didn't finish their myofunctional, we excluded them from the study because I didn't want a
Yeah.
diluted sample, right? So those who
Right.
did the whole 1 year of myofunctional, and it was
Mhm.
done with myofunctional therapists who were using the same protocol. So we tried to get the variables.
Mhm.
You'd be
Right.
amazed. You'd be amazed at the kids when we looked a year later who had residual AHI, their AHI had increased if they didn't do anything else. Increased.
Yeah.
Those who did
Uh,
myofunctional therapy, almost perfect scores. It's just
so that's
unbelievable. When
very
I,
similar to that
yeah,
study that Christian had done, except there was an expansion in the role in that
exactly.
in
Yeah,
his. He had just
yeah,
done it with the surgery. But yeah.
yeah. And the only other study like that was Maria Villa, who is from Rome. And she also kind of included nasal rinsing as part of it. So it kind of made it a bit hard to follow the study. But
Yeah.
her conclusion was 100% on
Same.
the control group who chose not to do myofunctional therapy or didn't do the exercises versus the
Mhm.
dedicated group that did. There was a huge difference in their AHI. So I think with that, there's certainly hope because I feel sorry for many myofunctional therapists who are totally dismissed almost as witchcraft. I mean, it's terrible
I've been
when you
told I'm
see.
practicing voodoo
Yeah, oh
before.
yeah, yeah. Like I
I
mean, we're not in the dark ages where what is it? They would tie you up and throw you in the water, see if you sank or something like that. I don't know. It's just
all I
and
know is like I see it work and I can't once I've
yeah,
seen this, the whole picture and the role of the orthodontist and what it does for people, I'll just keep plugging along and doing it because
right,
the proof has been in the pudding. One of the things I tell parents is that it's often, and I guess we kind of cover this, but specifically, like it is kind of puzzle pieces coming together.
yeah,
Just the surgery's not going to do it. Just the, I mean, you might have some isolated cases where that does happen, but
yeah,
generally they're going to have to do several different things to address this
yeah,
problem. And I see that all the time. One thing I see all the time too is we do have kids coming in here who had tonsil and adenoid removal a few years ago, like maybe when they're
yeah,
4 or they were, whatever. We have a lot of 9-year-olds for some reason, but they
yeah.
were fine for a while and now they're not.
Okay,
They're in the
okay,
same situation they are minus the tissues. And it's because, I believe like that the other pieces of the puzzle, they
yeah,
still have the jaws that are too small and
yeah,
the oral function and the nasal breathing, all that hasn't been rehabilitated. the
Yeah.
structure was improved. And so people do like, it would be nice, we do like a quick fix, but I do like to set people's expectations that, you're probably going to have to bring in a couple things at this, and it's going to, take some time. But
Actually, there's one last question I will ask you, and we can add this area is, I see so many children who've already had tonsil and adenoids removed, and then a year later, there's regrowth. And the parents kind of say, oh, geez, I vaguely remember being warned about that, but I just didn't think it'd be blockage so quickly. So can you answer that question? What do you think is a major cause of regrowth of adenoids and tonsillar tissue that have already been removed years earlier?
Yeah, I've seen that a few times, and strangely, I've seen it a few more times recently this last year in as little as 6 months. I have heard from like ENTs that maybe sometimes some of the tissue did not all get removed.
Okay.
And the body wants it to be there.
Yeah. Yeah.
And I do think a bit of allergies too playing a role with the inflammation in the area. Like the body's trying to adapt for it.
Yeah. And I think your point earlier, which is what caused the inflammation in the first place, right? Just napalming that area may not be the solution. Maybe trying to find, and that's why I think those people who tried the non-surgical approach and got the inflammation down and then has the T's and A's would probably be a more successful outcome in my humble.
I tell, even if families like they did, like say they did all the little natural stuff in the toolkit or whatever, and they worked through that and they still have surgery, your child was still better off. Like the outcome's likely to be better because, you got, let's say their vitamin D was low and we got it normal and their iron was low. And we got them at a, baseline healthier state to maybe get through that surgery, recover better.
Yeah.
There's really no harm in doing those things and getting your child functioning more optimally. So.
And then also the recurrent middle ear infections needing more than one surgery. So in Australia, we call it a grommet. I think you call it a plug or an ear tube or something. Yeah, tubes. Yeah. Parents also. I've had one kid that was about to have their third tubal or grommet operation, right? And then when you look at the research, and I'm happy to post some of this on there, improper swallowing is why the eustachian tube is not working, right? Mm-hmm. So rather than go through surgery, you'd be amazed how much research leads to expansion, developing the posterior vertical, like dominant molar buildups on deciduous teeth, right? And finally, teaching the kid how to swallow properly. And maybe, if a parent's listening to this, I want them all to swallow properly, which is kind of like, lips together, breathe through your nose, tongue hard on the palate, and your back teeth only just touching. That's a proper swallow. And guess what will happen? You will hear a little pop in your ear. And what is that pop? That's two very important muscles that are linked to the palate, tensor and levator palatini. And when they work in synergy, which is normal swallowing, you're naturally clearing that eustachian tube, right? So again, I'm so big on, we're talking about surgical intervention. Sure, T's and A's is what our topic was, but I'm so big in parents before they go down that grommet route, maybe try this myofunctional therapy and then assess. Because look, again, it's a very similar analogy. Your kid needs it. They've got a narrow palate. They've got a tongue thrust, blah, blah, blah. Why don't you just fix that? And if it improves that recurrent middle ear problem, bingo, you've avoided a surgery. If not, then at least you've tried every non-surgical outcome. So I think there's a great analogy between large T's and A's and not doing surgery first. Recurrent otitis media, you've tried all the antibiotics and still not, then maybe look at the swallowing pattern, before we launch straight into another operation. And I guess there's probably some nose and throat doctors listening to this that'll be cringing because they're saying, what are you? Yeah, right. But look, I want to make the point that I work with a lot of very good nose and throat doctors. And yes, sometimes surgery is the solution. We totally get it. So this is not one of those don't do surgery type podcasts, but it's all about how do you want your surgery to be more successful so you don't have to have a second surgery. It's all about what could I do? Because it's all about inflammation, isn't it? Right? This is all inflammatory responses. What could I do to try and identify the cause of the inflammation before I just go to that surgical pathway. So with that, Courtney, thank you so much. Great interview, and thanks for all you do. I'm sure many parents here would love to get in touch with you. So at the end of this podcast, if we could have your best contact email for a parent. Also, if you have a link to your support toolkit, I think many parents would love that. And, I'm sure I'll catch up with you at some
I'll see
meeting
you at some
in the
conference here
future.
in the US,
Yeah.
probably, or if I go out of the country. It was
Great.
my pleasure. I'm so grateful that you asked me to chat with you.
Okay. Thanks so much.